on advances in thalassemia treatment. We all know that due to routine visits to the hospital, the parents of thalassemic children are very much updated regarding the treatment. So if as a general pediatrician, if we don't know what is happening in thalassemia treatment right now, so it is very difficult to counsel the parents regarding that. I know many of my parents of thalassemic major patients who routinely come for the blood transfusion. They are themselves aware of the treatment, more advanced than us sometimes. So this CME will help us regarding the counseling of the parents. We are very much privileged to have Dr. Bageshree Seth Madam for guiding us regarding this, and Dr. Uddhav sir will moderate the session. Now I request our dear President Dr. Bageshree sir to give the presidential address.
Thank you, Vikas. Thank you very much. And good evening to all. Respected our expert, respected Dr. Bageshree Madam, Senior Pediatrician Mohite sir, Dr. Sasane sir, all the dignitaries on the board, of the board, and dear friends. I first congratulate you all for celebrating this Thalassemia Day and Thalassemia Month. Actually, this May is we are bothering of thalassemia in entire month. Dear friends, as you know that thalassemia, though it is preventable, but it is rampant in our country. Our country has become a capital of thalassemia, particularly in Southeast Asia. So why this is happening? This is just a so preventable disease, but just lack of knowledge. म्हणजे लग्नानंतर कुंडली किंवा ग्रह पाहण्यापेक्षा जर आपण ह्या ज्या गोष्टी पाहिल्या, काही HIV आहे, HBsAg आहे, थॅलेसेमिया आहे, HPLC टेस्ट जर केली, आणि मी तर म्हणेल की HPLC टेस्ट ही कंपल्सरी should be before taking admission in school, that should be compulsory. So this way we can prevent the thalassemia major, that is a very drastic disease. With this, we get more knowledge about it, we get more information about it from our experts. Let us learn from her. Thank you very much. Thank you. Over to you, Vikas. Vikas.
Yeah. Thank you, sir, for your guidance. Now I request Uddhav sir to take over the session and start the presentation.
Thank you, Dr. Vikas, and good evening, all my friends, seniors. Thank you, outside. I would like to thank Raigad IIT for giving me a chance to moderate this session. And I am very fortunate to introduce Dr. Bageshree Seth. I am feeling fortunate because when I read in your CV, she is so intelligent. The CV is of 3 pages. So I'm sorry that I had to cut short it. But today we are going to speak, Madam is going to speak on thalassemia, recent advances, and also basic care, and in the perspective of the office pediatrician should know. Dr. Bageshree Seth Madam is a professor and Department of Pediatrics in MGM Medical College, Kamothe. Since last 10 years almost, she is MD from LTMC Medical College. She is also DNB and DCH. She is working exclusively on thalassemia and HIV, hematology units and HIV. She holds different positions in that regards. She was also lecturer in LTMC College, and she is also a second expert on pediatric state AIDS clinical expert panel of NACO, Maharashtra State. She is also a chairperson of ethical committee, which is for important for the bone marrow transplant center in Borivali. She was a convener of scientific committee of Mahapedicon annual Maharashtra State Conference in 2012. She is also a member of medical education unit of MGM Medical College, Kamothe. She has various presentations on her name. That amongst them, she was a moderator in panel discussion in difficulties in hematology during the Mahapedicon 2012. She was also a speaker at webinar CME on Thalassemia Day on topics General Management of Thalassemia, organized by Navi Mumbai IIT on 7th May 2021. She is also expert speaker at webinar CME on case-based discussion of hematological disorder organized by Adolescent Health Academy, Nagpur in June 2021. She has various publications on her name. Out of them, some of our hemolytic anemia initial presentation of Wilson disease. Very interested. And also the quality of life in a children with thalassemia and their caregiver in India. It was there in an Indian Journal of Pediatrics in 2017. Also, she has a pediatric anemia profile in Indian subcontinent, Journal of Pediatrics Association of India. With this excellent CV, I would like to welcome Dr. Bageshree Seth, madam, to start her presentation.
Good evening all, and thank you Dr. Uddhav for the introduction. And I'd like to thank IAP Raigad for giving me an opportunity to discuss thalassemia with all of you all today, which is very close to my heart. So without any much further ado, I will start with my presentation. So as was the brief given to me, I'll just share the screen. Are you all able to see the screen?
Yes, madam.
Am I audible?
Yeah, very well.
So the brief given to me was to talk about recent advances in thalassemia from an office pediatrician's perspective. So before I begin, I would like to first thank all my thalassemia patients, young and old, because these are the people who are, these are the kids who have enriched my knowledge of thalassemia and enriched my experience also while I've been working with them for the last almost 10 to 15 years in MGM Kamothe. So I'm really indebted to them, because of which my knowledge about thalassemia has enhanced. Also, I would like to especially thank two institutes which have helped me in bringing up my knowledge of thalassemia, namely LTMG Hospital Sion in my early days, and now MGM Hospital Kamothe for the last almost 15 years that I've been working there. So with this, I'd like to start with the presentation. And since we are discussing management of thalassemia today, I would like to emphasize on three aspects of management of thalassemia. One, of course, is the standard care, which relates to transfusion, chelation, and monitoring, which is the standard which is available to most of the patients. So we have about 1 lakh patients of thalassemia in India today. And for the common patient, or the aam aadmi as you would call it, this standard of care is available at most centers where they are taking the treatment. So transfusion, chelation, and monitoring for the long-term side effects and complications remains the mainstay or the backbone of treatment. But of course, with advances in care, we need to also be abreast of what is happening new in terms of the management of thalassemia. So I will touch upon the advances in care and what's new in thalassemia. And of course, we all know that all these things, that is the advances as well as the standard of care, are placing a large burden on the healthcare system as well as on the patient's family as well as on the patient himself. And therefore, our main focus or emphasis from now on should be more on prevention and going towards zero thalassemia births, which has been rightly emphasized in the video which was shown by Dr. Chandra. So we are all aware of the basics of thalassemia. So I'll just highlight a few aspects about the standard of care and then go over to the advances. So if we look at the pathophysiology of thalassemia, we all know that when we talk about thalassemia, the most prevalent thalassemia which we are managing is the beta thalassemia as opposed to the alpha thalassemia. And in beta thalassemia, we all know that there is a absent beta chain synthesis, beta globin chain synthesis, or there is a deficit or decreased amount of beta chain synthesis which is happening because of a genetic defect, of course. And that gives rise to a relative excess of alpha chains. So we are all aware again that adult hemoglobin is comprised of 2 alpha and 2 beta chains. And because of decrease in beta chains or absent beta chains, there is a relative excess of alpha chains. And this relative excess of alpha chains is the one which is responsible for most of the problems or the pathophysiology of beta thalassemia. So this excess of alpha chains gives rise to a little membrane instability of the RBCs, because alpha chains will precipitate within the red cells. And this will cause destruction of the RBC precursors in the marrow itself, giving rise to what is termed as a ineffective erythropoiesis. That is, erythropoiesis is not effective till the last stage, when the mature RBCs should be coming out in the marrow. The RBCs get destroyed in the marrow itself. This gives rise to anemia, as we are all aware, which can result in pallor, fatigue, poor growth, hepatosplenomegaly, increased GI iron absorption as its side effects. And of course, because there is anemia, which is like a persistent anemia, the patient will have to be managed with red cell transfusions, which will eventually result in iron overload in various organs, namely the liver, heart, and the various endocrine organs. Now, because there is anemia and there is tissue hypoxia, it also causes stimulation of erythropoietin, which results in bone marrow expansion. However, because there is a genetic defect of beta chain synthesis, this bone marrow expansion also does not result in improving the hemoglobin status or correcting the anemia. And eventually it will give rise to facial, skeletal deformities and also osteopenia. So this is in short the pathophysiology which determines most of the treatment modalities in thalassemia. Now, we are also well aware that clinically the child with thalassemia will usually present between 6 to 24 months of age, which is when the hemoglobin F levels usually go down and hemoglobin A becomes the predominant hemoglobin. However, in thalassemic children, because hemoglobin A production is deficient, therefore the clinical age of presentation will typically be between 6 to 24 months of age. And again, we are all aware that the common symptoms which a child will come to us with are progressive pallor, failure to thrive, fever, recurrent infections, irritability, poor feeding, and signs of pallor, hepatosplenomegaly, sometimes later in the course. And this child, if he belongs to a high prevalence community, as was mentioned by Dr. Nitin Shah in the video, then we must suspect that this child could be possibly a thalassemia. So presence of pallor in a child between 6 to 24 months of age and associated hepatosplenomegaly should make us suspect in a high-risk community that this child could possibly be a thalassemia. So once we suspect that this child could be possibly a thalassemic, we would of course have to go ahead and investigate this patient. And on investigation, the classical features that are seen, as obviously there is anemia in the form of low hemoglobin. So usually the patient will present with a severe anemia. Another important feature that we see is a very high WBC count. If it's done on an automated counter, then we usually see a very high WBC count. And this WBC count, which is high, is actually not a true high WBC count, but it is because of the presence of nucleated red blood cells in the peripheral blood, which gives rise to a pseudo high count in the patient's blood. So usually in a thalassemic patient, if we are seeing in a suspect thalassemia patient, if we are seeing a very high WBC count, we must always ask the pathologist to give us a NRBC count, that is the nucleated RBC count or normoblast. In the peripheral smear, they must look for this and give us a count to that effect. So usually in normal patients, you will not see any nucleated RBCs in the peripheral smear, or at the most about 1 or 2 nucleated RBCs. Nucleated RBCs normally will not appear in the peripheral blood smear, but whenever there is a patient with thalassemia, because there is an ineffective erythropoiesis and there is a stress in the marrow, whenever there is a stress in the marrow and there is a extramedullary hematopoiesis that is occurring, you have these nucleated RBCs being thrown out into the peripheral blood smear. So you can see normally to an extent of about 30 to 40 or even more than that nucleated RBCs per 100 WBCs in the peripheral smear of a patient with thalassemia. So a high count should make you suspect in the setting of a possible thalassemia that this could definitely be a thalassemia. And of course, the peripheral smear, which is consisting of anisope, poikilocytosis, microspherocytes, ovalocytes, so all types of cells which would be seen on the peripheral smear as is depicted over here. So this makes us suspect on the basis of the CBC and peripheral smear that this patient could possibly be a thalassemia. And as we are all aware, the confirmatory diagnosis would be attained only when we do a hemoglobin electrophoresis or HPLC as it is called nowadays, because the method of checking for the hemoglobins has changed. And so HPLC is the go-to method or the go-to diagnostic test when we want to confirm the diagnosis of thalassemia. As you can very well see in this report, which is displayed over here, a 1-year-old child who presented to us with a similar picture, we did a HPLC and the HbF was found to be 98.2% at the age of 1 year. When you expect it to be less than 1%, it is actually 98.2%. So the major fraction of hemoglobin is made up of hemoglobin F, which more or less confirms the diagnosis of beta thalassemia homozygous. However, always when we get this report of HPLC suggestive of a thalassemia, one must, in today's day and age, always do a genetic study for the type of mutation, because the type of mutation can be correlated to the phenotypic presentations also, and therefore always as a baseline before transfusing the patient, a collection of a sample for HPLC and collection of a sample for doing a genetic study should also be done in order to look for which mutation has caused this beta thalassemia major. It goes without saying that you can, in addition, confirm the diagnosis by doing the parents' HPLC. And in the parents' HPLC, you will come across a high HbA2, which is confirmatory diagnosis for beta thalassemia trait. So you will usually end up getting both the parents with beta thalassemia trait. Sometimes you may have a variety where you may have hemoglobin E in one of the parents and hemoglobin and a beta trait in the other parent, in which case the child may present with, which is called as hemoglobin E beta thalassemia, which may sometimes have a little delayed presentation, that is after 2 years of age. So at baseline, when you are suspecting a patient to be a thalassemic, always take the samples, draw enough samples before you transfuse the patient so that you can do a HPLC testing for the patient and also go ahead with the genetic study or the mutation studies for the patient. Sometimes we also send alpha thal mutation studies in patients who have presented a little later in life, because an associated alpha thal mutation may be a modifier or a genetic modifier of the presentation of thalassemia. So some of the patients who also have alpha thal mutations along with beta thal major may present a little later in life in the form of a non-transfusion dependent thalassemia. So especially patients who are presenting, say, at around 4 years or 5 years of age, along with beta thal mutation studies, we must also send the sample for alpha thal mutation studies to see if there is any genetic modifier which has caused a little late presentation of thalassemia. So I would like to just clear the terminologies once before I go ahead with the therapy. So earlier we used to term patients as beta thalassemia major or beta thalassemia intermedia. Now these terms have been replaced. The new terminology is transfusion dependent or non-transfusion dependent thalassemia. So as I said, transfusion dependent thalassemias are the ones which are presenting typically between 0 to 2 years or 6 months to 2 years of age. And they are the ones which are having either an absent production in both the genes, that is a beta 0 variety, or a beta 0 beta plus variety of thalassemia. So generally the transfusion dependent thalassemias will have such a type of a genotype and will present early in life, that is between 6 months to 24 months of age. Their anemia would be severe and they would require 3 weekly to 4 weekly, that is regular transfusions. And the complications in such patients are mostly related to transfusions. As opposed to this, you have another variety which used to be earlier called as Thalassemia Intermedia. Now it is termed as non-transfusion dependent thalassemia. However, it does not mean that these patients do not require transfusion at all. It just means that these patients require transfusions less often as compared to patients who require transfusions on a 3 weekly or a 4 weekly basis. Now, as we look at the genotype of non-transfusion dependent thalassemia patients, we find that these patients could have a different variety of genotype. That is, they could be a beta plus variety, wherein both the genetic mutations are the ones which are having a reduced beta chain synthesis and not an absent beta chain synthesis. Similarly, HBE beta thals or beta thal along with alpha thal or hereditary persistence of fetal hemoglobin, all these syndromes can have a non-transfusion dependent presentation, usually presenting after 2 years of age. Having moderate anemia, usually they maintain the hemoglobin between 7 to 9 grams % without transfusions. Sometimes they may require transfusions during episodes of stress or when they have infection or fever. And the complications in such patients are usually related more to extramedullary hematopoiesis. That is, they will have significant hemolytic facies, they will have a significantly large spleen, they will have a lot of cosmetic disfigurement, short stature, etc. And these are the things which will give rise to complications rather than transfusions, because they are relatively less requiring transfusions as compared to TDT or transfusion dependent thalassemia. So now, with this background of having established that a patient has thalassemia and determining whether he seems to be a transfusion dependent depending on age of presentation or a non-transfusion dependent thalassemia, we all know that the mainstay of therapy whenever we diagnose a patient with thalassemia, of course, we have to counsel them, and the mainstay of therapy which we are going to tell them upfront or at the beginning itself is going to be related to transfusions. So let's just look quickly through what are the different aspects of transfusion therapy, which all of us as pediatricians must know and practice correctly. So what do you do before you actually start the transfusion program in these patients? So at baseline, of course, as I said, counsel the parents about the disease course and the treatment which will ensue. First and foremost, get the SBTC thalassemia card made for these patients, because the SBTC thalassemia card goes a long way in procuring free blood for the thalassemia patients. So according to the government resolution, free blood can be obtained by the thalassemia patients from the government blood banks as well as from the blood banks like Rotary, etc., against a SBTC thalassemia card. At baseline, before you actually transfuse the patient, you must always screen these patients for transfusion transmitted infections so as to establish whether this patient is already at baseline not having any of these transfusion transmitted infections. Suppose the patient has been going to other doctors and you are transfusing this patient for the first time, it is always better before you transfuse the patient for the first time at your center that you establish whether or not this patient is having any of these TTIs. Initiate or complete the hepatitis B vaccination, because it will help prevent hepatitis B in these patients. And of course, do a genetic study at baseline, as I already mentioned. Another important aspect that we must look at is doing a Rbc antigen typing. That is, the entire profile, we always type the blood groups which are ABO and RH, but we don't type for all the other minor blood groups as a routine. So in thalassemia patients, because they are going to receive multiple transfusions throughout their life, it is always advisable that at baseline you have a complete profile of the Rbc antigens, including the other minor antigens like KEL, Duffy, MN blood group, etc., which in some cases, if there is a facility, you may, every time when you are transfusing the patient, you may test for all these antigens when you are checking the blood bag, or you should at least have a profile of the patient ready so that in the future, if this patient happens to have hemolytic reactions because of minor blood group incompatibility, you can initiate testing for minor blood groups from then on. So Rbc antigen typing, which is done at most labs and also done at NIH, must also be done at baseline. If it has not been done at baseline, we can always do this Rbc antigen typing anytime pre-transfusion by molecular methods instead of serological methods. And of course, the last and most important is that we must enroll this patient in a government scheme if it is possible. So if in centers like ours, we enroll these patients in government schemes so that they can get full benefit from the thalassemia package that the government gives in Phule Yojana. Now, transfusion therapy in thalassemia involves various questions or aspects as to why to transfuse, whom to transfuse, when to initiate transfusion, what to transfuse, how much, how often, and how to transfuse. So I'll again quickly go through the transfusion therapy, these aspects of transfusion therapy. We all know that we want to transfuse thalassemia patients first and foremost to correct the anemia. Second, to suppress the ineffective and extramedullary erythropoiesis, which will give rise to a lot of complications. Try to maintain an optimal hemoglobin level, which ensure normal growth and good quality of life in these patients. So this is the basic aim or goal behind transfusing thalassemia patients, so that we maintain an optimal hemoglobin level and ensure that the patient grows normally and also enjoys a good quality of life. So whom should we transfuse and when should we initiate transfusion? So if we have diagnosed a patient, say at about 1 year of age, and confirmed the diagnosis by doing an HPLC and doing a genetic study, the lab criteria mentions that if we find this patient to be dropping his hemoglobin to less than 7 gram percent on 2 occasions, more than 2 weeks apart, he is a candidate for starting chronic transfusion therapy. In some patients, when the hemoglobin remains above 7 grams percent, you may think of this patient as being a non-transfusion dependent thalassemia, and you may reserve this chronic transfusion therapy for later. So if in a child who's maintaining hemoglobin above 7 grams percent, we may not immediately initiate chronic transfusion therapy. However, if in such a child we are seeing that over a period of time, the child is having a poor growth or not growing adequately, if he's having significant extramedullary erythropoiesis in the form of hepatosplenomegaly or hemolytic facies causing facial changes and cosmetic disfigurement, or if he's having fractures, then in these cases, even if the child is maintaining a hemoglobin of more than 7 grams percent, we may decide to start such a patient on a chronic transfusion therapy. Now, what to transfuse? We are all well aware that in thalassemia, we have to say no to whole blood, and packed red blood cells is the only option that we have in case of transfusion therapy. So we must give packed red blood cells, and as is understandable, we have to give ABO-RH compatible blood. And as I mentioned, we can do an extended match wherever feasible. So if we have a baseline red cell phenotyping available of the patient, red cell antigen typing available of the patient, we can ask for an extended match whenever it is possible or in whichever blood banks it is being done. Also, the blood should be screened for TTIs, that is for HIV, Hep B, Hep C, VDRL, and malaria, which is done in most standard blood banks. The blood should be leuko-reduced either by using pre-storage leucofilters in the blood bank itself, or we have to use bedside filters when the blood bank is not having pre-storage leucofiltration available. The blood could be saline washed if the patient is experiencing severe allergic reactions. Then we may resort to, in addition, doing a saline washing or a triple saline washing, as it is called, which will remove the plasma proteins from that blood bag so that it will not give rise to any allergic reactions in the patient. And most important is that the preferred blood product, the packed red blood cell, has to be less than 2 weeks old. So there's no point in transfusing a blood which is more than 2 weeks old, because it will not give rise to a significant rise of hemoglobin. And also the red cells which are there in the blood bag will not survive in circulation after transfusion for a significant period of time. So it is as good as a wasted blood transfusion, and therefore we must make sure that the blood is preferably a week old, but never less than 2 weeks old. So try and get as fresh blood as possible. Of course, in the month of May, we experience a lot of shortage in relation to donors coming to the blood banks to donate blood. So we have to make do with whatever is available, but try and see that as and when you transfuse these patients, the blood should be less than 2 weeks old. So these are the important things we need to take care of when we are transfusing blood to these patients. I mentioned about bedside leukocyte filters. So again, this is a must and an optimum care aspect of transfusion therapy. That is, every patient who's receiving transfusion for thalassemia must receive transfusion along with a leukocyte filter attached to his blood bag. So there are various types of leukocyte filters which are now available, various companies which are there which provide leukocyte filters. So all blood banks also should probably make it available at the blood bank itself, so that whenever they are giving blood out to a thalassemic or issuing blood to a thalassemic, they must also give a leukocyte filter along with the blood whenever they are issuing blood to a thalassemic. Now you can have leukocyte filters which can be double use leukocyte filters. That is, if a patient is receiving 2 blood bags at a time, then there are some filters which will have 2 ports which are there. So the same leukocyte filter can be used for 2 bags, one after the other. Now, leukocyte filters are important because they cause a reduction of the WBCs which are there in that. Sometimes some amount of WBCs are always there in the packed red blood cell bag, even though we have centrifuged the bag and we have ensured that it's a RBC bag or a packed RBC bag, but there will be still some amount of WBCs which are there in the bag, and we need to reduce these WBCs to less than 1 × 10⁶ per liter, because presence of WBCs can give rise to non-hemolytic febrile transfusion reactions in the patient. So if he's repeatedly getting fever with every transfusion, we must ensure that we start off using a leukocyte filter with the transfusion for thalassemics. Now, filters also help to reduce HLA alloimmunization. So if a patient is going to go in for a bone marrow transplant, which most patients now, the newly diagnosed ones, we must ensure that they are given the option of a bone marrow transplant. So in such a case also, it will help in reducing the HLA alloimmunization. It will help prevention of transmission of viruses like CMV, and also prevents the transfusion-related acute lung injury in patients. So this is a standard of care, and there is no way that we should be transfusing patients with blood if they are thalassemics without a leukocyte filter. So this is mandatory now in the optimal care of thalassemics. Now, next important point is how much should we transfuse, or what should be the optimal pre-transfusion hemoglobin. Now, most centers in India follow the moderate transfusion regimen, wherein we try to maintain the hemoglobin, which is pre-transfusion hemoglobin, at around 9 to 10.5 grams %. So though we may say that we want to maintain it at 9 to 10.5, practically it is very often not possible. And therefore, we often get patients who are coming to us because they are coming a little late, or they are not able to arrange blood. They are usually coming to us at about 8, 7, or sometimes even lesser than that. But we must make an effort. If we are transfusing only a few thalassemics in our office practice, then we must make an effort that we try and reduce the duration between two transfusions, so as to ensure that the patient maintains the pre-transfusion hemoglobin at 9 to 10.5 gram %, and also ensure that we are giving adequate amount of blood at that particular visit, so that we are raising the hemoglobin to at least more than 13 grams %, or approximately at around 12 to 13 grams %. So now, if we give this, if we keep this pre-transfusion hemoglobin at this level, it will effectively suppress the erythropoiesis. That is, it will suppress the ineffective erythropoiesis, and also it will limit the iron overloading. So if we are trying to maintain pre-transfusion hemoglobin more than this level, then it will result in significant iron overloading. And therefore, this is the transfusion regimen which is being followed by most of the centers. But try as far as possible to not let the hemoglobin drop below 9, and transfuse patients at 9 or more than 9 grams % of hemoglobin pre-transfusion. Now, how much should we transfuse? So normally the target increase in hemoglobin level, if we are transfusing a patient at around 9 to 10.5 grams %, we are expecting that the hemoglobin level should be at least 3 to 4 grams % more after the transfusion. And therefore our target is around 13 to 14, not more than 14, but approximately about 13 to 14 grams %. So we are expecting a 3 to 4 gram % rise in the hemoglobin after we have transfused. So if we look at the hematocrit of the donor red cells, that is the hematocrit of the packed red cell bag, most often the hematocrit has been estimated to be about 60%. So if we have a bag with a hematocrit of about 60%, which you can ask the blood bank. So occasionally they monitor the hematocrits of their blood bags, and roughly it amounts to about 60%. So in a 60% hematocrit bag, if we are transfusing about 15 ml per kg, we will ensure that the hemoglobin rises by about 3 grams %. If we give about 20 cc per kg, the hemoglobin will rise by about 4 grams %. So some sort of a maths is required over here, so that if we know that a pre-transfusion documented hemoglobin is about 8 grams %, so we will, if we give about 20 ml per kg, we will be able to raise the hemoglobin to approximately about 12 or more than 12 grams %. So always look at the pre-transfusion hemoglobin and then determine how much to transfuse. So it should not be a random give 1 bag or give 2 bags, but estimate the pre-transfusion hemoglobin, see how much rise will occur by giving 15 to 20. So the upper limit is always 20 cc per kg. We should not at one time be giving more than 20 cc per kg. Sometimes if the child has come with us with a very low hemoglobin of about 5-6 gram %, initially we give just about 5 to 10 ml per kg, so that there's no volume overload happening in the child. And then we immediately after about 12 hours, we give a second aliquot by looking at the post-transfusion hemoglobin after the first transfusion. So always ensure that during that one episode, if the child has come with a low hemoglobin, we are able to jack up the hemoglobin to more than 12 or approximately about 12 to 13 grams percent when we are discharging the patient. So we should never just arbitrarily give blood as 1 bag or 2 bags, but calculate how much ml per kg you are giving. Some bags are small bags which are only having about 250 ml. Some bags sometimes are about 350 ml of blood. So we have to also look at how much we are transfusing, because if there is a small bag, then we will not be able to reach that 15 to 20 ml per kg of blood. So in the transfusion regimen, the points that we have to think of are that maintaining pre-transfusion hemoglobin of 9 to 10.5 grams percent is a must. We must transfuse every 3 to 4 weekly. We must transfuse approximately 15 ml per kg of packed cells. Sometimes, if it's a slightly lower hemoglobin, we may have to go up to about 20 ml per kg of packed cells also. The rate of transfusion should not be too slow or it should not be too fast. So keep the rate at generally about 4 to 5 ml per kg per hour. So approximately a bag of about 300 ml or so would be over in about 2 to 3 hours. So most of these patients who are coming at about hemoglobins of 9 to 10 grams percent are not in failure. And there are studies which have been done where the transfusion rate has been increased to higher than this also, and transfusions get over in about 1 to 2 hours without any complications in the patient. So blood should not be transfused too slowly, otherwise it may give rise to hemolytic reactions, especially when the ambient temperature is very high. So always see that you are giving it at a rate of about 4 to 5 ml per kg per hour. If a patient is in failure, then you may have to give at a lower rate of about 2 to 3 ml per kg per hour. Ensure that there is the post-transfusion hemoglobin does not exceed 14 grams percent because it will cause complications in the patient. Now, sometimes we face practical problems, as I said, that the pre-transfusion hemoglobin may be lower than 9 grams percent, or sometimes patients may come with pre-transfusion hemoglobins which are higher than 10.5 grams percent. In such cases, amount transfused can be increased or decreased by about 15 to 20% if the patient presents with either lower or higher pre-transfusion hemoglobin, but never exceed 20 cc per kg transfusion at a time. Sometimes we may consider altering the interval between transfusions. If the patient is consistently coming with lower hemoglobins, then we may reduce the transfusion interval to 2 weeks. If the patient is consistently coming with higher hemoglobins, that is, his HB is not dropping significantly, then we may increase the transfusion interval to about 5 weeks also, which usually happens in infancy. We usually tend to transfuse about 5 weeks intervals. And when the patient is an adolescent or at the time of puberty, we may have to reduce the transfusion interval to about 2 weeks. Other things which we have to take care of or note are that we must maintain a careful record of the blood transfused. We must maintain a record including the date, the weight, the pre-transfusion hemoglobin, the volume which was transfused, any adverse reactions if they happened, either fever or allergic reactions, and how much transfusion was given to the patient in a year, that is in ml per kg per year. If it is exceeding 200 ml per kg per year or 220 ml per kg per year, then it could be because of a significant splenomegaly and hypersplenism, because of which there is destruction of the RBCs and there's an increased requirement in the annual requirement. It may be more than 220 ml per kg per year. Always jot the mean pre-transfusion hemoglobin throughout the year, how much has been the mean pre-transfusion hemoglobin, which helps us to analyze whether we are calling the patient at late intervals or whether we should be calling the patient a little early. And of course, testing for TTIs should happen 6 monthly in these patients. So this is some sort of a patient record book which we use in our center, and it is used in most centers across the city of Mumbai, where we are able to keep a proper record of transfusions and also a proper record of chelation, monitoring, etc. And this book, if the patient carries with himself, even if he goes to some other center, like it happened during COVID times, that there were people who were displaced from one place to another, and therefore this gives a proper record of what has been going on in the patient's life till date. Now, as I said, benefits of transfusion therapy are basically that it helps to promote normal growth, allows normal physical activity, adequately suppresses the marrow activity, and also minimizes the transfusional iron accumulation because we are giving a moderate transfusion regime. despite it giving a moderate transfusion regime, we will still end up having iron overload in these patients because they are every month or every 3 to 4 weekly receiving blood which is containing iron. So therefore, chelation becomes an important aspect of the treatment program of these patients. And we will look at each of these questions one by one. So iron overloading is bound to happen with transfusion therapy because the human body lacks the mechanism for removing excess iron. And with every blood transfusion that we are giving some amount of iron to the patient, which is to the tune of about 10 milligrams of iron per kg per month, that is per 28 days that the patient gets transfused. And because iron is highly reactive, it generates free radicals, it damages the lipid membranes and the cell organelles and DNA and can cause cell death. So whenever we are transfusing a blood which is containing iron, the transferrin binds to the iron, but when the transferrin binding capacity is exceeded, the non-transferrin bound iron starts to increase. Now, the problem with this non-transferrin bound iron is that it is taken up by the various tissues in the body, namely the myocardium, the endocrine organs, the hepatocytes, and it gets stored there as ferritin and hemosiderin. And this will cause cardiac failure, pituitary damage, endocrine complications, liver fibrosis, cirrhosis, etc., which will follow in the absence of chelation. So we are well aware of the problems of iron overload also. And therefore, we need to balance the intake of iron and the excretion of iron in order to maintain a safe level of iron and also help reverse organ dysfunction, which may have already occurred. If a particular patient is not on chelation therapy, you may already have organ dysfunction. And with chelation therapy, you may be able to reverse the organ dysfunction in some endocrine organs. So it is important that patient does not take episodic chelation therapy, but has to be on consistent chelation therapy and must adhere to the chelation therapy. So it's very, very important that patient is told about adherence and compliance to chelation therapy, because if he's just receiving it intermittently or as and when he likes to take the chelation therapy, then these short periods of interruption which happen can be significantly damaging and can give rise to a very high level of non-transferrin bound iron, which may cause a lot of complications in all the organs. So we have to talk at least 5 to 10 minutes every time the patient comes for a transfusion to ensure that he's adhering to the chelation therapy and not just taking it as and when he wishes to take it. So we all are aware that we must start chelation early, and usually we are starting chelation at about 2 years of age, when approximately about 12 to 15 transfusions have been received by the patients. And how we determine is by starting off doing the ferritin levels or the serum ferritin levels when the child is approximately about 1.5 to 2 years of age. So when we find that consistently on 2 or 3 occasions, the child's ferritin is exceeding about 1000 nanograms per ml, that is the time when we are deciding to start the chelation therapy. So there are various studies which have shown that the earlier you start the chelation therapy, the better, because it results in reduced NTBI or non-transferrin bound iron. So usually at 2 years of age, it is a must that any patient who's under your care should be started on chelation therapy. So what are the chelators that we start with? So nowadays we are starting only oral iron chelators. Desferrioxamine, which is the subcute or intravenous form of chelation for iron, is nowadays reserved only for patients who are going to be undergoing a bone marrow transplant, or if there is a significantly high iron overload in the heart, then we may give an intensive chelation therapy with desferrioxamine for about 3 weeks or so. But otherwise, routinely, we are using oral iron chelators, which could be either in the form of deferiprone or kelfer, as goes by the trade name, or deferasirox, which is also known by the trade names of Desirox, Deferijet, etc. So we have these various oral iron chelators, which are life-saving for the patient. Otherwise, they will end up developing significant iron overload. So we know about different pros and cons of these oral iron chelators, but to summarize in a sentence, the best oral iron chelator, which is most compliant in terms of usage, is deferasirox, because it has to be given only once a day, and it is a good hepatic iron chelator, as well as some amount of cardiac iron chelation also occurs. However, the best cardiac iron chelator is deferiprone or kelfer, which has to be given thrice a day. So many patients do not end up complying with thrice a day dosage and end up taking it only once a day or twice a day. And therefore, by far, practically in all the new patients or the younger patients, most of these patients would be on oral deferasirox, which has to be taken only as a once a day dosage. Of course, we have to know their side effects and keep monitoring these patients for the side effects also. Sometimes when, despite using the maximum dose of one oral ion chelator, we are still having ferritin trends which are showing more than 2000 or more than 2500 nanograms per ml, we may opt to start a combination chelation therapy, wherein we give Kelfer or Deferiprone along with Deferasirox, that is Desirox, and that acts somewhat like a shuttle. That is, the Kelfer removes the Deferiprone removes the iron from the heart and gives it into the peripheral circulation, from where the Deferasirox removes it further and excretes it into the urine. So some sort of a shuttle hypothesis, as it is called. You can use a combination of two oral ion chelators also, which has been tried in various studies. Now, how would you monitor iron overload is, of course, by doing a 3 monthly, or sometimes some people would do it 6 monthly also. Serum ferritins must be monitored 3 to 6 monthly to see what is the trend of serum ferritin. So annually, for serum ferritins, you may look at the trend as to whether it is persistently above 2000 or 2500 nanogram per ml. Then there is a significant risk of cardiac disease if there is a persistently high serum ferritin. So persistently high serum ferritins are more significant as opposed to low serum ferritins. In low serum ferritins, you may or may not have significant overload in the organs. But if there is a high serum ferritin persistently, it is a significant indicator that there could be a significant iron overload in the heart. Usually, we don't do invasive procedures like liver biopsy because it is difficult. The sampling could be inadequate and it cannot be used on a repeated basis for monitoring trends. So by far, we rely on serum ferritin levels. Another important modality, which again has become a must in the standard of care, is the MRI for iron overload. That is a cardiac T2 star MRI, which is a non-invasive technique and tells us about the estimation of iron concentration in various organs like the liver, the heart, the pituitary, as well as the pancreas. The only drawback is that it is a costly procedure, that is costs about 8,000 to 9,000 rupees per sitting, and it requires sedation in younger patients, cannot be frequently done. So the standard of care again is that we must do it annually, at least starting from about 8 to 10 years of age, which is when we expect the iron overload to have started occurring in various organs. So it is important to have an annual record, or at least once in 2 years, we must have a record of the cardiac T2 star MRI in the patient to determine whether there is a significant iron overload in the organs, and because of which, if there is significant iron overload, we may intensify our chelation therapy, increase the dose of chelation, or use a combination oral ion chelator if there is significant iron overload in the heart. So this is the center, 1 or 2 centers in Bombay only, where this cardiac iron overload is determined by doing a cardiac T2 star MRI. And as you can see over here, it gives you the values. And if you have a myocardial loading, which is showing milliseconds, or time taken to blacken the heart is more than 20 milliseconds, it suggests that there is no cardiac iron overloading. Also, it gives you an estimation of the hepatic iron overloading and the pituitary and the pancreatic iron overloading also. Also on this cardiac MRI, we may get to know the biventricular function and the LV ejection fraction also. So as I mentioned, cardiac T2 star MRI, we must ensure that all our patients who are above 8 to 10 years of age keep getting it done every year, at least once. And if there is no cardiac iron overloading, we may do it once in every 2 years also. So that record also must be maintained, and that should be used as a basis for intensifying the chelation therapy if we find that there is a severe cardiac iron overload. So our target is basically to keep the serum ferritins less than 1000 nanogram per ml. And in cardiac T2 star MRI, our cardiac T2 star should be more than 20 milliseconds. Reinforce compliance to chelation on every visit. Intensify chelation if the trends are indicating high levels. So consistently ferritins are high, then we have to intensify chelation. Consider using combination chelation therapy, as I mentioned before. So if the patient is compliant with chelation and we are monitoring this iron overload at regular intervals, we can significantly improve survival in thalassemia patients. So actual survival has been shown to be better if the patients are compliant with chelation and if we are monitoring iron overload regularly in these patients. So lastly, coming to monitoring of thalassemia in the standard of care. So as I said, in the initial decade of life, in the first decade of life, our main focus has to be on transfusions, giving regular transfusions and starting chelation in these patients. Whereas in the second decade of life, that is after 10 years of age, when most of the complications of iron overload start occurring, our main focus has to be on determining whether these endocrine complications are there in the patient. So we must monitor for iron overload, we must do a cardiac MRI, monitor the serum ferritin trends, work up these patients annually for endocrinopathy in the form of doing a fasting blood sugar, or OGTT, a thyroid profile, a vitamin D profile, plotting the Tanner staging every year, and also looking for bone health in the form of doing a DEXA scan. Plus, of course, the chelation toxicity has to be monitored, and every 6 monthly, transfusion transmitted infection checking has to be done so that we can pick up early if, unfortunately, these patients end up having one of the transfusion transmitted infections. So this is about monitoring of a thalassemia patient. So as you can see, this a transfusion regime as well as the chelation therapy in these patients is somewhat like a lifelong therapy which they have to continue taking, and therefore there was a lookout by scientists, by doctors, etc., to see whether there could be some curative treatment for thalassemia, and thus it resulted in different advances in the cure and care of thalassemia. So we have a lot of advances which are now on the horizon, and let's look at at these one by one. So we have advances in the form of correcting the globin chain imbalance by methods like HSCT, gene therapy, and gene editing. Or there could be the targeting of ineffective erythropoiesis, which can be done by various drugs. The new drugs on the anvil are the luspatercept and sotatercept, as well as you could use fetal hemoglobin inducers. So there are various drugs which can act as fetal hemoglobin inducers, namely drugs like hydroxyurea, which we routinely use for patients with HBE beta thalassemia, also for sickle cell thalassemia. Then other inducers like erythropoietin, butyrate, thalidomide, these are still undergoing trials, and there is no definitive treatment in terms of commercial treatment available, but these are all undergoing trials. So these are the various advances in care and cure of thalassemia. So let's look at them one by one. So first and most important, or probably the only curative treatment option. So some of these treatment options which I discussed, right, which I highlighted just now, are curative options, whereas some of them are the ones which are just going to be modifying the disease in terms of reducing the transfusion dependence or reducing the transfusion requirement. So as of now, or as of date, the only curative treatment option which we have available worldwide is HSCT, or hematopoietic stem cell transplantation. Now, you can use this term alternatively with bone marrow or stem cell transplantation, depending on what is the source of these stem cells. So if the source of the stem cells which is obtained from the donor is the bone marrow, then it is called bone marrow transplantation. If the source of cells is from the peripheral blood, so if you obtain these stem cells from the peripheral blood by stimulation of the stem cells, then it is called as a stem cell transplantation or peripheral stem cell transplantation. And the third source could also be an umbilical cord blood, which can be used to procure the stem cells. So it is overall, all these things come under the blanket terminology of hematopoietic stem cell transplantation. And as I said, it is probably the only curative treatment option available to thalassemics as of today. So now let's look at the various factors which will contribute to this bone marrow or stem cell transplantation being the only curative option. So what is the best age for doing a HSCT or a bone marrow transplant? What determines the outcome of the HSCT? Who can be the donor for this patient? What is the cost and what is the success rate? We look at all these issues one by one. So as was stated in the video earlier, it was mentioned that the child was already 17 years old and therefore he had exceeded the age when possibly a HSCT or a bone marrow transplant could have been done. So partly this statement is true, partly it is now changing, or sort of the options are now changing even for children who are older. So the best age, of course, for doing a HSCT, which most of the transplant physicians would prefer, would be between 2 to 5 years of age. So why this would be the optimum age or the best age for doing a transplant is because iron overload and all the other complications which are related to iron overload are going to be absolutely minimum or non-existent in these patients, because as I said, most of the overload related complications are going to start occurring after 8 to 10 years of age. So our focus, so earlier, say about a decade ago, we did not have many centers who were offering bone marrow transplant or HSCT to thalassemia patients. So probably we had just about 1 or 2 who were more focused on doing transplants for leukemia patients or malignancies or aplastic anemias. But now suddenly there are so many centers in the city of Mumbai itself, in public sector as well as in private sector, who are offering HSCT or bone marrow transplant. Almost half a dozen centers are there where we could refer our patients. So my earnest request would be that the moment you diagnose a patient with thalassemia, that is, even if he gets diagnosed at about 6 months of age, we must start the process of working up this patient for whether he could be a transplant recipient. So we must start working up for the donor right from the word go itself, so that we are able to ensure that these patients go in for a transplant early, and the outcome or the thalassemia free survival or overall survival in these patients is also very good. So ideal age would be 2 to 5 years, but now centers are doing transplants for patients who are 8 to 10 years old also, with procedures having improved, with techniques having improved, with various other drugs having come up. Therefore, even 8 to 10-year-olds and sometimes even above 10-year-old also, certain centers who have got a lot of experience, they are even doing transplants in patients who are young adults also, even up to the age of about 22 or 25 years of age also. Various centers are doing transplants for older patients also. Of course, there is a significant risk associated with the procedure, but they are being done in various centers. Now, what determines the outcome? The outcome of the transplant is determined very significantly by the quality of chelation that the child has received. And therefore, it is very important that we start the chelation at an early age, and we ensure that the patient is compliant to chelation, and that we monitor the chelation process properly so that we can modify or intensify the chelation if required. So usually what the transplant physicians would look at when they are determining whether this patient would be a high risk or a low risk for a transplant is what is termed as the PESARO classification for the risk factors which will be associated with the transplant risk. So the 3 most important factors that these PESARO classification gives in terms of risk factors for transplant are chelation, hepatomegaly, and portal fibrosis or liver fibrosis. So class 1 patients are the ones who are on regular chelation, they have no hepatomegaly or no portal or liver fibrosis. And in these patients, the overall survival is to the tune of 94%, with a thalassemia-free survival of about 87%. So these class 1 patients are a very good candidate for transplant. And class 2 patients would have 1 or 2 of these factors which are present, whereas class 3 patients would have all the 3 factors which are present. That is, their chelation is irregular, they have a significant hepatomegaly which is more than 2 centimeters, sometimes exceeding 2 centimeters also, and they also have a significant liver fibrosis. So as you can see, automatically the class 3 patients, the overall survival reduces to 70%, and the thalassemia free survival also reduces to 58%, and the mortality, the transplant related mortality, will go on increasing from class 1 to class 3. So we have to try and ensure that most of our patients who are diagnosed young are referred to these centers, so that the entire process of working up these patients for transplant begins at an early age, and they can be going through this transplant process at an early age. So the moot question is, who can be a donor? Now, you could have an autologous transplant or you could have an allogenic transplant. So now what we follow in the centers is allogenic transplant, where you usually end up having a HLA identical sibling. So about 20 to 30% of the patients will be able to have a full match with their sibling, that is HLA identical sibling, which is about 20 to 30%. So the remaining about 60 to 70% patients still don't have a sibling donor or a matched sibling donor, as it is called. So MSD stands for a matched sibling donor. So then we have to resort to looking for whether one of the parents or a family member is a matched family donor, which happens rarely. Only in cases where there is a consanguineous marriage between the parents is where you may get a match between the parents and the child. So this is again a very rare entity, or rarely it happens in consanguineous marriages. In such a case, you may have to resort to looking for a matched unrelated donor, an HLA identical unrelated donor, and this is possible only through donor registries. So there are certain donor registries which are there in our country also, as well as abroad, and through these donor registries, though they are less in number and there are not many people who volunteer to become part of these donor registries, you may be able to enroll these patients in these donor registries, and if they find a match in these donor registries, they can serve as the unrelated donors who are HLA identical to the particular patient. So because it's only a 20% or a 30% chance that the patient will be able to obtain a HLA match with the sibling, we have to look for other options, and donor registries is the other option. Now, there is another form of donor which some centers are looking at, is what is termed as a haploidentical donor, or what is termed as a mismatched family donor. Now, in this case, the mother is taken as the donor for the child, even though she may not have a full match with the child. So even a half match or a partial match with the child is being tried in centers who are conducting haploidentical bone marrow transplants. So here the concept is basically that because when the baby was a fetus and he was inside the mother's womb, there was some amount of feto-maternal and maternal-fetal exchange of blood which was happening. Therefore, the baby is generally immune tolerant to the mother's cells. And so mothers can be used as donors even if they don't have a full match with the child. Now, when I say full match, we are looking at the various HLA loci. So the HLA loci which are looked at when we are doing an HLA typing, or a HLA typing report will show, are the HLA A, HLA B, HLA C, HLA DR, HLA DQ. These are the various loci. And there are samples are taken either from the blood sample, EDTA sample, or a buccal swab can be used for sampling for HLA. Now, there are two varieties of HLA typing which the labs may perform. One is a high resolution and the other is a low resolution, wherein if you are looking at a family donor, either a sibling or a parent, then you may even do with a low resolution where even a 6x6 match would be sufficient. But if we are looking at an unrelated donor, a matched unrelated donor, or a MUD as it is called, then we need to look at least for 10 to 12 loci to match in order to be able to take up this patient as a donor. So the HLA typing of this patient and the donor. Now, this I've shown you a report of a patient and his sibling, who's also his brother. The loci are completely matching on all the 10 loci. So all 10 alleles are matching, which is a 100% match at the locus. And this patient is shortly going to be going in for a bone marrow transplant at Borivali Center. So important to tell you that thalassemia minors can also be a donor. So if the sibling is a thalassemia minor, or if the parent is a thalassemia minor, they also can serve as donors, in which case the patient's thalassemia major or transfusion dependent status gets converted into a carrier status, which again is asymptomatic. So donor is not a contraindication for, minor is not a contraindication for being a donor. Coming to the next question as to what is the approximate cost, which we should be able to tell. So it depends on various variables. That is, of course, the age and the risk involved. That is depending on if it's a high risk or a low risk patient, or what are the blood products which are required, which are the immunosuppressants which are being used by that center, what are the antibiotics which are being used. So approximate cost would range from anywhere between 15 to 20 to 25 lakhs, or even more at some centers. But some centers in the public sector domain, because they are sourcing their funds from various NGOs and organizations, donor organizations, in those centers, the approximate cost of treatment would be just about 1 to 2 lakhs. However, because there's a long list of patients who are waiting for getting the transplant done, and there are not many centers who are doing it, it is the need of the hour that more MBBS graduates or the more pediatricians who are coming out of MD pediatrics should train as transplant physicians, so that there will be more hands to work, there will be more centers who will have trained physicians who will be able to do transplants, and therefore we can tackle the number of patients who require a transplant as opposed to the number of centers which are offering transplants to these patients. Now, success rate, as I said, depends on the Pesaro risk class, and most of the patients, about 70 to 80% of them who undergo transplant, get cured of thalassemia. That is, they'll have a thalassemia-free survival. Now, that is about bone marrow transplant, or HSCT. Next kid on the block or new kid on the block is what is termed as gene therapy. Now here gene therapy would mean either addition of the gene, addition of the normal gene, or editing the mutated gene. So both these methods are tried in gene therapy. And here the procedure basically involves collecting the stem cells from the patient's blood. So the thalassemia patient blood, there is a stimulation given by giving injections of GCSF, wherein there'll be more of stem cells which will be there in the peripheral blood. From the peripheral blood of the patient, by a process which is similar to plasmapheresis, the stem cells are removed by cytopheresis, and the functional genes are then added to the DNA of these stem cells via a viral vector. So either a lentivirus or a retrovirus is used as the viral vector, and the functional gene or the normal gene is added to the DNA of these stem cells of the patient by a viral vector. In the meantime, the patient's body is subjected to or the marrow is subjected to a marrow ablation. That is, all the abnormal stem cells which are present in the patient's marrow are ablated by using marrow ablation or chemotherapy. And then the added stem cells are infused back. That is, the stem cells in which these DNA has been added are then infused back into the patients. Then these infused patients, these infused stem cells will home in into the marrow of the ablated marrow of the patient, and then the functional genes can sustain a long-term production of the working hemoglobin. Now, with this gene therapy or gene addition, the patients can have transfusion independence. Usually, patients who are beta plus variety or the beta plus beta 0 variety genotype. In these patients, especially this sort of a technique has been tried only in the older patients or in adults. And there we have seen that there has been significant transfusion independence. That is, patient does not subsequently require transfusions at all. So this is a technique which is there on the anvil, a very costly technique, now has become commercially available. I'll just tell you about that. But there is another technique in as opposed to gene addition, whereby you can edit the gene. That is, a precisely directed mutation repairs the gene, the defective gene in situ, or it can cause reactivation of the hemoglobin F production, which will also lead to a little less transfusion dependence in these patients by activating the hemoglobin F production. So as I was talking about commercial availability of this gene therapy, in 2019, the European Commission has given approval, commercial approval to gene therapy, which goes by the name Zynteglo, but the cost is prohibitive. That is, it's about $1.8 million to undergo this gene therapy. So it is out of bounds or not possible for most of the patients which are there in our country. But maybe over a period of time, say a decade down the line, this gene therapy will become more affordable as the demand rises. Now, gene therapy for these patients is applicable only to those patients who are not entirely lacking beta chains. As I said, it's successful only in those patients who are either the beta plus variety or the beta plus beta 0 variety. And therefore, those who are the beta 0 variety do not benefit through gene therapy. Also, in older patients where marrow donor is not available, so if they have not found a unrelated donor, a sibling donor, or a family donor, then in such cases, in older patients, one can try gene therapy. And of course, those patients who are older and not eligible for HSCT because of the risk involved, that is, they may have significant iron overload, they may have significant fibrosis or hepatomegaly. In such cases, also gene therapy will work. So this is the basic scheme or the mechanism or procedure which I just mentioned to you all earlier, wherein by apheresis, the stem cells are collected from the patient, then they are purified and the vector is introduced. And these cells are then again with quality control procedures, after doing a partial or a full myeloablation in these patients, therapeutically infused back into the transfusion dependent thalassemia patient. And that would significantly reduce the transfusion dependence, or even the patient will become transfusion independent. So we have to frequently monitor the child with repeated hemoglobins every month to see whether the patient is maintaining a hemoglobin above 9 to 10 grams per cell. So that was those two therapies which are available, which will alter the marrow of the patient. Now, there are certain therapies which are available which target the ineffective erythropoiesis. That is the last stage erythropoiesis, which is ineffective in these patients, can get modified by certain drugs which are now available commercially. So one of these drugs is called as luspatercept, and it is available commercially as Reblozyl. It was approved by the FDA in November 2019 with the trade name of Reblozyl, but the cost is very prohibitive because this one vial of 25 milligrams, so patient is usually given 1 milligram per kg per dose subcutaneously every 3 weeks, and one vial of 25 milligrams. So if a patient is say about 25 kgs, then he will require this one vial every 3 weeks, and he would require to spend $3,000 per vial on a continuous basis because every 3 weekly it has to be given. So this sort of a therapy is not something which is going to cure the patient of thalassemia. These therapies are targeted only to reduce the transfusion burden. So this drug has been found to reduce transfusion burden by at least 20 to 30% from baseline over a period of about 24 to 48 weeks. So if you are consistently giving this drug, the transfusion burden or the transfusion requirement is going to come down significantly. So this drug luspatercept is now available commercially, but of course, again, because of the cost, it is prohibitive and it is out of reach for or out of bounds for common patients of thalassemia. So this is one of the drugs which is currently being used. The other important class of drugs are what are termed as the fetal hemoglobin inducers, that is, they induce HbF. So as we all very well know from the pathophysiology, the HbF is persisting in the child's blood or the peripheral blood as the predominant hemoglobin. But over a period of time, this HbF production also reduces. And therefore, in order to sustain this HbF production or induce HbF production, which will give rise to reduced number of alpha chains, decreasing the ineffective erythropoiesis thereby, and also there'll be increased production of HbF molecules to carry the oxygen by the RBCs. So for all these things, you have various drugs which are inducing HbF, and the most important among them are, one is hydroxyurea, which we are routinely using, as I said, in sickle patients. Also, hydroxyurea has been found to be very effective in patients of HbE beta thalassemia. Most of the HbE beta thalassemias which we encounter are the ones who are manifesting at around 8 to 9 years of age with suddenly an increased transfusion requirement. So till about 8 to 9 years of age, they usually don't require any transfusion. At 8 to 9 years of age, suddenly their transfusion requirement increases and they become chronically transfusion dependent. So in such patients of HbE beta thalassemia especially, the hydroxyurea drug has a very effective role to play. Also, it is effective in patients of Thalassemia Intermedia or the non-transfusion dependent thalassemia by inducing the hemoglobin, fetal hemoglobin. Sometimes some studies have also shown that along with increasing the gamma globin gene production, hydroxyurea is also known to augment the beta globin genes, and thereby it will also improve the production of the beta globin genes. Now, in hydroxyurea usage, we have to do one genetic testing to see whether hydroxyurea would be effective in patients with Hla Intermedia or non-transfusion dependent thalassemia. So we subject these patients to what is termed as a XMN1 polymorphism testing. So if these patients are found to be plus or homozygous for XMN1 polymorphism, or even heterozygous for XMN1 polymorphism, they are associated with higher hemoglobin F levels if we treat these patients with hydroxyurea. So hydroxyurea has been found to be more effective in patients who are having XMN1 polymorphism present, because this XMN1 is a promoter at the region of the gamma globin gene, and thus it induces the production of higher levels of hemoglobin F. Now, though hydroxyurea is a good drug, especially for sicklers or for patients with HbE beta thalassemia, for thalassemia major patients, it does not really have a significant response. So there are low number of significant responders. Also, hydroxyurea toxicity has to be monitored every monthly to 2 monthly. So it can cause significant bone marrow suppression. The ANC levels may drop, the platelets may drop, and also it may cause liver and renal toxicity. And therefore, if we are starting a patient on hydroxyurea, we will have to closely monitor for adverse events or side effects. Though in my personal experience, I have found that most of these patients who are on hydroxyurea don't end up having bone marrow suppression, even though most of my patients, some of my patients of sickle, as well as those who are HbE beta thal, have been taking hydroxyurea for almost 4-5 years at a stretch. We have never encountered any of them coming with significant bone marrow suppression. Because if you exceed the level of cutoff of 20 to 25 milligram per kg per day, is when significant bone marrow suppression will set in. If you continue to manage these patients between about 15 to 20, maximum up to 25 mg per kg per day, then you will not have significant bone marrow suppression. So practically, it is a good drug to use, though it is known to have significant side effects, but personally, I have not experienced significant side effects with hydroxyurea usage. Now, other HbF inducers which have also been tried in various studies, most importantly, one of them is erythropoietin, which apart from being a HbF inducer has also been shown to have an antioxidant effect on the red cells. So there is a lot of oxidative stress on the red cells which are there in the marrow, and that also gives rise to ineffective erythropoiesis. So giving erythropoietin as again subcutaneous injections every once in 3 weeks or so reduces the oxidative damage of the red cells and causes induction of HbF, and thereby again can reduce the transfusion dependence. Other drugs which have been tried in various studies are 5-azacitidine, sodium butyrate, but they had to be withdrawn because there were significant side effects associated with these drugs. Nowadays, another drug which is there on the anvil and is being tried in various studies is thalidomide, which we are all very well aware of. It is a synthetic glutamic acid derivative, and it is also known to promote gamma globin gene. It induces gamma globin gene synthesis or expression, and thus also causes a significant reduction in transfusion requirement. However, one has to be careful while using thalidomide in especially adolescent girls or girls of reproductive age group if they are thalassemics. And peripheral neuropathy also has been known to be a significant neurotoxic adverse effect of thalidomide. So thalidomide is still not the standard of care. There are trials which are going on to compare whether standard dose of thalidomide and low dose of thalidomide, what is the optimal dose which will have a good therapeutic effect. Again, as I said, all these drugs are only going to reduce the transfusion requirement, and none of these drugs are going to absolutely cure the patient of thalassemia, and therefore we have to use it only for those patients who are requiring transfusion significantly or have significant iron overload, so that we can reduce their transfusion requirements. So thalidomide is a drug which has been studied, and if you are aware, then April 2021, there was an article in Indian Pediatrics on efficacy and safety of thalidomide in patients with transfusion-dependent thalassemia by Dr. Jagdish Chandra from Delhi. And this same group is also trying to look at whether a low-dose thalidomide can be equally effective in reducing the transfusion requirement in these patients. So still trials are on, and it is not yet used as a standard of care. So as you can see from the various advances which I highlighted, that HSCT seems to be the only feasible curative option for thalassemia as of today. And because HSCT also is a costly or an expensive option as opposed to transfusion therapy and chelation, which also is costly because it goes on lifelong and it's going to be going on till your second, third decade of life. And therefore, the only option that remains for us to reduce the burden of thalassemia on the society, on the country as a whole, is prevention. So there are various ways or methods in which we can help to prevent thalassemia. So maybe in this year, on the occasion of Thalassemia Day or Thalassemia Month, as Dr. Wankhede called it, our focus could be at least trying to make our district free of thalassemia. So having the country freed of thalassemia, our country is not a small country like Cyprus. And also being a democratic country, we can't make things mandatory for patients. So our only option is to make patients aware of this disease or make the common public aware of this disease and try to use different preventive measures by which we can at least make our district, Raigad district, free of thalassemia. So what are the various options which are available in prevention? This is probably my last thing about prevention, maybe another 2-3 slides and I'll be done. So carrier detection, genetic counseling, and prenatal diagnosis. These are the 3 arms of prevention. And as comes to carrier detection, as rightly mentioned earlier, pre-marriage screening in persons of reproductive age group by conducting camps in schools or in colleges. So when they are in that reproductive age group, the patients themselves or the students themselves can be made aware about this disease. So somebody talked about using HPLC as a mandatory requirement for entry into schools. But I think that is too early an age for the children themselves to understand the significance. So if these schools and colleges, maybe at around 9th standard or 11th standard, if they are doing a screening for all the reproductive age group children of about 9th, 10th, 11th, 12th standards, then the students can be made aware of the disease also, and they would be knowing about their trait status, and they would remember about their trait status much better than the kids when they are entering school. Another strategy which is practiced is what is called as preconception screening. That is after marriage but before conception. Both especially the high risk communities, both the spouses should be tested for HPLC for knowing whether they are Hla trait. Then of course there is antenatal screening. Women in the first trimester should get antenatally screened by the obstetricians. But very often this doesn't happen because women don't end up coming in the first trimester, and it's probably too late to screen these mothers when they are already in their second trimester or end of their second trimester. And also husbands of carrier women should be screened in the antenatal period. And another strategy is what is termed as cascade screening, wherein the extended family, the siblings, the relatives, all the other reproductive age group members of the extended family of the affected child must be screened. So whenever we are counseling a parent for treatment modalities in that particular index child, we must also give counseling regarding screening all their sisters, brothers who are in the reproductive age group, so that there are no further thalassemia births in that particular family. Now, you are all aware of doing a carrier detection by using a CBC with a red blood cell indices as well as an HPLC, where a high HbA2 level of more than 3.5% would be indicative of a carrier status. And of course, on CBC, if we find that a patient is having a little low hemoglobin of around 10 grams percent or 9 to 10 grams percent with a relatively high RBC count for that hemoglobin level, and more specifically an MCH of less than 27 picograms with MCV of less than 80 femtoliters. This is again, if we first screen with the CBC, these are the patients whom we would set aside for doing an HPLC. Those who are having a good hemoglobin of 14-15 grams percent need not necessarily be subjected to an HPLC. However, they can always do an HPLC if they wish, but especially these sort of patients must be set aside for doing an HPLC and looking at their HbA2 levels. Now, if we have noticed that these patients are these people who are being screened are having Hla trait status, we have to go ahead with genetic counseling. And you all are very well aware that being an autosomal recessive disorder, in each pregnancy there is a 25% chance that the child born will be a thalassemia major. In each pregnancy there is a 50% chance of having a child who's a trait, and a 25% chance that the child will be unaffected. So especially in patients, both parents when they are carriers, or when one parent is a patient and the other is a carrier, there is a significant risk that the baby born will be a thalassemia major, and therefore this genetic counseling will serve as the first step for talking about prenatal diagnosis. That is, these parents, if they are going to be having a baby, then it's important that in the late first trimester or in the early second trimester, they undergo a procedure. The mother undergoes a procedure of either a chorionic villus sampling or an amniocentesis, either at around 10 to 12 weeks of gestation for a CVS, or at around 16 to 18 weeks of gestation. The earlier the better. So a CVS is better because it gives you enough time for the reports to come to counsel the patient. If the child is an affected fetus, then you counsel the patients for going ahead with the MTP. So this sort of a genetic testing is done for the fetus. So as you can see over here, the parents' genetic testing is showing this particular mutation to be present. So this is the father's mutation, this is the mother's mutation, and the father and mother are both beta thalassemia minor. The fetus has been screened for these mutations by a chorionic villus sample and has been found to have one of the mutations. That is, the father's mutation is present in the fetus, but the mother's mutation is not present, and therefore the fetus has been declared to be a beta thalassemia minor. So if it's a beta thalassemia minor, then the parents can go ahead with this conception and take it to term. However, if both the mutations are detected in the fetus, then it is termed as a affected fetus, and the advice to these parents would be to go ahead with a medical termination of pregnancy or abortion. There is another entity which is called as pre-implantation genetic diagnosis, where in countries where MTP is not permitted, So before implantation, you can do an entire screening of that particular blastomeres. Genetic testing can be done in couples who have an affected fetus on more than one occasion. So they have been trying to have a baby, but every time they go for a prenatal diagnosis, the baby comes, the report comes back as an affected fetus. So in such a case, they may go in for a pre-implantation genetic diagnosis, where by in vitro fertilization, the fertilization occurs in vitro, and then the blastomeres are screened for a complete genetic profiling of the patient, of the baby, and thus the report comes as affected or unaffected. Also, sometimes this pre-implantation genetic diagnosis can be used by parents to have an unaffected baby with a HLA match for the affected child. So if they want to have a baby for the affected child to have a complete HLA match in the sibling, then a pre-implantation genetic diagnosis can be performed. So these are the various things which one can do for prevention of thalassemia, and therefore we have to make this message loud and clear to all our patients. So use different posters in your OPDs, in your clinics, etc. At least in this month also and throughout the year also, to tell them that a simple blood test can help save any child, and especially your child, from a lifetime of suffering. And therefore, it is very vital at this hour that we stop this menace of thalassemia, and we can then divert our resources towards managing the children who are already having thalassemia in a much better and in a much efficient way. So I'll stop over here. Thank you all for a patient hearing.
Thank you, madam. Thank you for such a lucid. You almost touch every aspect of the thalassemia, basic as well as recent advances also. To summarize things, you had already mentioned the role of CVC, but I think it is the role of more of MCV and also RDW. I think there is the initial things. See, also you had mentioned that increased WBC count does not mean that it is because of nucleated RBCs. Again, you are told genetic typing is a must. It is not only HB erythropoiesis, but also genetic typing is a must. Then you can diagnose transfusion dependent or non-dependent on basis of that. Also, you says before starting transfusion therapy, the Rbc antigen typing is a must. Rule out any other rare blood groups or any, so we can avoid the further complication. You should say transfusion therapy vaccine should not be less than 2 weeks old. So that is very important message. Again, WBC filter has to use. The goal is to maintain the HB between 9 to 10.5 gram %. Again, transfusion should be around 10 ml to 20 ml per kg. But if HB is low, then we should rule out the CCM. I think percentage of CCM in these children are very less because they are already used to it. Again, chelation therapy, I very well mentioned the role of serum ferritin at our level, pediatrician level. We can always monitor the level, ferritin level. If it is anything persistently more than 1000, then one should always start the chelation therapy. Again, cardiac risk factor is more when it is more than 2500 nanogram. So in that patient should be referred back to a centers to see for the risk factors. You can do a MRI after the age of 8 to 10 years. You already says that is cardiac T2 MRI. And the treatment part, for definite treatment, you says bone marrow transplant is the best. Again, you have touched upon the haplo-identical donor. So I think there is a new concept which has been come. So it is very, very well. So I think we had also mentioned on the drugs, erythropoietin, especially we have seen a lot of patients which started on erythropoietin, injectable erythropoietins, and they are coming. So that is also good. We have touched upon that. Now, what I wanted to ask you is this SBT thalassemia card you says, is that blood free even in the private blood bank, or it is only about the few certain blood banks only?
As per the government resolution, all government blood banks have to give it free of cost. But from recent directives by the SBTC mentioned that on this card, ideally Thal patients have to get blood free of cost from all blood banks, at least from the charitable blood banks or from the semi-government organizations. So even private blood banks are included, but I don't know how much is followed. And the government resolution definitely says that Thals should get free blood.
and you said no whole blood at all. If there is no package, then only it is absolutely no.
Now there is no concept. So earlier there used to be a time when component therapy was not available in many of the blood banks, and people would just hang the blood bag upside down and then let it semi-pack and then give the semi-packed blood. But now in today's day and age, there is no concept of whole blood being given to transfusion dependent thalassemics, because it is going to be useless, because you are going to give such a big volume of blood and your hemoglobin rise is not going to be even 1 gram%. So we have to make sure that these patients, suppose they are staying in an area where there is no component therapy available in the blood bank, you must refer them to a center where it is available, because it's once a month or once in 3 to 4 weeks that the patient will have to travel to that center. But one has to ensure that the only way that we can give blood to these patients is packed cells.
I think almost all blood bank now have a facility of
Component therapy. Yes.
We can always think of.
Yeah.
Now, there is very important point is that WBC filter. I think cost of WBC filter is not much high. So I think emphasis of that using the WBC filter whenever, even we are giving the pack cell, it is hardly cost around say 1200 or something. And
Yes.
if it is you procure the bulk, so it should be not costing more. So
Absolutely.
And in prevention, you says that if you want to make Raigad as a free of thalassemia, I think first stage is to educate our doctors, because that is very important, because that is how we can counsel, because even the Ayush people also, so you should be able to counsel, you should educate them more. So with this, I think thank you. Anybody want to ask any? There are hardly any questions.
So just like during the ORS and breastfeeding weeks, I saw that all the doctors of IIP Raigad were putting up posters in their clinics. So there were nice posters which had come up in their clinics. I think we also need to mobilize some thalassemia awareness posters.
And should be whole year.
Madam, do you have such posters?
Yes, we had a poster competition for our MBBS students also recently, and they drew very nice posters, which I'm going to now make them like printed posters, convert their posters into printed ones, and I can surely share them with all of you all as soon as
we can take many prints on it and we can distribute amongst our members.
Yes, sir.
I think is this anybody want to ask anything? Sir, Mohite sir, you want to?
Hey, just one suggestion. We should have Dr. Bageshree's lecture every Thalassemia day.
Yeah.
We get a yearly
Sir, Bageshree madam is good for
update.
not only for thalassemia, she is good for other hemoglobinopathies also.
I know, but I mean, this is something, a lot of new information she has given. Obviously, those drugs are difficult to remember, and many of them are not sort of within the reach of a common man. But at least, just now I saw the comment from Dr. Nilima Bhandarkar that the efficiency of this bone marrow transplant is so good. They don't know, and it's not known to many people. But it is really a very kind of effective way of a cure of thalassemia. I mean, remember the days when we passed out our MD 30 years ago. Thalassemia is a death sentence. Keep on giving blood till 10, 12, 15 years and then die. That's the definition. It's like Dr. Ambedkar used to say, as the nurse from Sion NICU, what is a preterm baby about 40 years ago? This is a baby who is born before time by 1 month, 2 months. He comes to the NICU, he becomes breathless and he dies. That's a definition of a preterm. So similarly, 30 years ago, thalassemia to us was this is a child who is born. He keeps on drinking blood. After 10 to 12 years, he dies. And now perhaps it's totally a different story. And I don't think the day is very far away when you may have voluntary donors. Like today when a cochlear implant started, it was costing 6 to 7 lakh. And today it is done at 50,000, sometimes free also in many of the things. I'm sure people are going to support thalassemia bone marrow transplant also equally effectively. I mean, what's the difference? It's 10 to 12 lakh. And these philanthropic people with CSR and kind of things, I don't think it's very far away. But what she stressed is very important, prevention, most important. I suppose, I mean, this project we thought about 2-3 years ago at the Raigad level, and here Pramod as a IIP Raigad. I think by next Thalassemia Day, we should have Thalassemia Detection Center free of cost in one of our units in Raigad itself. We should have a Thalassemia Detection Center free of cost. It's not very difficult. You can have a screening test done on your routine CBCs, and those are like Minzer's index is one good screen test. So those who are willing in that, get the HPLC done, and maybe I mean it's not really costly. If you can
Sir,
work out per month, it won't be working more than 100 rupees, and that's not really at all cost.
Even HPLC
I
is
wanted to mention
free
one
at
thing,
government
sir.
center.
I wanted to mention one thing, that all Mahalab, they are doing it free, and all your USTs and even PSCs, the Mahalab attachment is there. If you
But
decide,
Mahalab is doing it free, you mean to say?
yes, they are doing it free.
But that's not
Because
what
the cost is there.
HPLC.
Sir, cost is there by the RCS program. The cost
But
is
that,
there.
even HPLC they are doing free.
Yeah,
Yes, sir. Yes.
But are they collecting the samples from private patients?
Sir, we have to
Yes,
refer the
you
patient
have to send, you have to refer them to government.
PSC.
डॉक्टर ताळणीकर मराठीत त्याला म्हणतात झारीतले शुक्राचार्य. कळलं का?
हो सर.
There are a lot of red tapeism in this. Actually, it should be made open, free everywhere. Because
Sir,
even if
I
you
available
take
आहे
one
म्हणजे
in
आपल्याकडे
10,000,
only thing is lacking is awareness.
Central government is giving a lot of emphasis and lot of budget for hemoglobinopathies prevention and detection. So this HPLC is actually available at free of cost in a lot of government centers. But the thing is that we have to push all these patients, especially like I said, the cascade screening. There must be a screening of at least all the affected, all the relatives of the affected child. And also something we must do so that at least the college going students, everybody knows their trade status when they are about 17, 18 years old. So those two ways in which we can probably bring down the numbers. If we ourselves can have a lot of awareness sessions in the colleges of Raigad.
I think as a Raigad IP, let's take it as a challenge. Within the next 5 years, we should achieve a status where there won't be a thalassemia boy or child born in Raigad. Let's take this challenge. We need to coordinate and work with the government authorities. We can have our screen centers in our own labs. And once we see something likely, we can coordinate with the government.
सर प्रॉब्लेम असा येतो की गव्हर्नमेंट सेटअप मध्ये ते फ्री आहे महालॅबला मी सांगितलं होतं, पण लोकांना ना गव्हर्नमेंट सेटअप मध्ये जायचं नसतं. त्यामुळे जबाबदारी अशी आहे, मला असं वाटतं आपली जबाबदारी अशी आहे की लॅब इज व्हेरी गुड लॅब. सर एनएबीएल अक्रेडिटेड लॅब आहे खारघरमध्येच आहे. दे आर व्हेरी गुड क्वालिटी ऑफ टेस्ट ऑल्सो. आपण जर लोकांना ऍटलीस्ट या टेस्टसाठी जर गव्हर्नमेंटला अप्रोच करायला सांगितलं आपल्या पीएससीला, तर तिथून हे होऊ शकतं सर. फक्त
Sir, my experience is that HPLC is free at government center, but they do not know. त्यांना जर विचारलं की HPLC कशासाठी करतात ते
माहित नाहीये. तेच मी म्हणलं की आपल्या आयुष डॉक्टर
पण ते HPLC फ्री आहे हे मला आता कळलं तुम्ही सांगितलं तेव्हा. इवन माय लेवल आय डोंट नो इट्स फ्रीली अवेलेबल. हाऊ डू यू एक्सपेक्ट आयुष अँड ऑल दोज पीपल टू नो?
तेच मी म्हणलं आपल्याला फ्री करायचं असेल तर त्यांना
we need to organize a system wherein first we keep everybody informed. Secondly, all the newly married couples, even before, like, see, about 20 years ago, Downs first is born. You are preventing second. Today, we are preventing the first itself. That's what perhaps is the thing which is required in thalassemia. So rather than it's as important as kind of preventing hypothyroidism. Hypothyroidism is equally bad, which is again a lifelong morbidity. And this is something which is death sentence in most of them. So let's take it, Pramod, rather than having multiple kind of projects, small projects, let's take one important project for next 2 or 3 presidents together. We'll have every taluka having its detection center as a primary lab, coordinate with our local PHC or local district hospital, or at Panvel level, maybe our commissioner, and request them that the samples which we send for HPLC get it done free. Now, if the patient is not willing to go there, we'll collect the sample and we'll put our boy to the work. And he will deliver it, and we should get the report. Something of that sort. Perhaps we need to really work out this system
with the government.
Yeah. We have to have.
More so because it's a tribal belt, Raigad, na? So there is going to be a lot of Adivasi population whom you can prevent thalassemia.
Yes.
Fund भरपूर असतो.
Not only thalassemia, madam, we are having sickle cell also.
Sickle also. Especially in Katkaris, we have a lot of sickle.
Yes.
And the Thakar and Mahadev Koris, a lot of thal. So entire Raigad district only is got a lot of tribal population.
And the last question is that is there any role of splenectomy?
Splenectomy. So in my 75 patients that I have in our center, there is only one child who has undergone splenectomy till date, and the other who probably might be undergoing because she's about 15, 16 years old. Hailing from Latur, keeps taking transfusions at different centers, so very badly transfused, under transfused, irregularly transfused. So only if you reach a situation where you have a large spleen which is causing significant hypersplenism, And with whatever way you are not able to ensure that you are able to give 2 weekly transfusions to these patients, and every time after 2 weeks they come down with hemoglobins of 4 and 5, that is a stage where in older patients you might have to consider knocking off the spleen rather than having the child suffer like that. So it's not nowadays, if we are able to manage the transfusion and chelation part optimally, properly well, then you don't need to subject any child to splenectomy. But we still have some older patients who may require because they are not well transfused or optimally transfused.
Thank you, ma'am. Thank you.
Yeah.
Thank you, Dr. Dhananjay.
Yes, sir.
Yeah.
Thank you, sir. 8th May is celebrated as World Thalassemia Day. And on this occasion, we have organized this wonderful CME to discuss the various aspects related to thalassemia management. We are really fortunate to have Dr. Bageshree Seth, madam, a stalwart in this field, as a speaker. On behalf of IIP Raigad, I would like to thank Dr. Bageshree, madam, for her wonderful presentation as well as answering all the queries in depth. I'm sure we will definitely benefit from this session in managing thalassemia patients in a better way. And we must have learned all the recent advances in this thalassemia management. Thank you, madam. Sincere thanks to Dr. Uddhav sir for his wonderful moderation. Heartfelt thanks to Dr. Hemant Gangulia sir, the MAHA-IP president, Dr. Mohite sir, the chairperson of IIP Intensive Care Chapter, for his valuable inputs, as well as his suggestion as always. Dr. Jay Bhandarkar sir, state convener MAHA-IP, Dr. Sasane sir. Sincere thanks to Dr. Wankhede sir, the president Raigad IIP, Dr. Vikas More sir, the vice president. Finally, sincere thanks to Dr. Vishal Rao sir for making this Zoom platform available for this session. And sincere thanks to all the delegates who have attended this session. Thank you very much.
Thank you, madam. Thank you very much.
Thank you.
Very much. Thank you. Good night.
Thank you, madam. Thank you. Good night.
Thank you.